Well, thank you again all for being here today. We have a day of a lot of information, so we will start with Jett Foundation. About Jett Foundation, if you don't already know us, our mission is to help families and individuals impacted by Duchenne, but we were started, I think we're going on 26 years now, by a mom, Christine McSherry, who just wanted to help her son. So these are our 4 main pillars of engagement, and that's kind of what we'll talk about going forward. But this picture here is the majority of our team. There are a few missing members, but we have all of our team. This was WDAD last year. Trina and Jessica are unfortunately not here, and then we also have Emily Hubert, who is our development events manager on our team as well. So one thing we really like to focus on is our welcome packets. This is a really great resources for families, clinicians, friends, anybody that you would like to know more about Duchenne or resources for the Duchenne community. This is definitely where I would recommend you go. We have not only Jett resources, we have resources from PPMD, Cure Duchenne, Got Transition, so we have other organizations as well. So some of the things that it includes is just general resources, female carrier resources specifically, includes a Dan & MD children's book, clinical trial cheat sheet. We do know that clinicaltrials.gov is not the easiest to navigate, so we try to help with a little cheat sheet. It doesn't have all of the information, but it has most of the critical information you should need to know, and we are looking to update it to provide some more information to help make decisions. We also have support letters from ambassadors and a lot more in that as well. So we also just added a transition timeline, so kind of giving you an idea of when to transition out of pediatric care and what that looks like. Family support, this is an old slide now, but we do have 3 support groups currently. Our Porch Night support group, which is for, I think we need to change, it's not just moms, but caregivers, female caregivers that are caring for boys with Duchenne. These are bi-weekly, and we will have 4 in person this year. Our first one will be in Texas in May. We also, led by Trina, have Carrier Conversations, which is once a month. We alternate between Thursdays and Saturdays at the moment at 11 a.m., but this is for carriers to come and talk about what they're experiencing and what they're feeling, what their needs are at that time. Not, if there's a caregiver issue, but about you and yourself, and we want to make that space. And then we just opened, coming up on April 12th, which will also be led by Trina, is Caregiver Connections, and that is for caregivers, moms, dads, aunts, uncles who are caring for a child, a female child or adult that is impacted by Duchenne. And then we do have our 2 resource specialists, Trina, who you know, and then we also have Jessica Campbell, who is a mom. Her son is, I think, going on 18, who are assisting us as well. So family workshops, which is what you are here for today. We have 4 of these every year. We are in New Orleans. Next month we'll be in Charlotte, North Carolina. In October we're looking at, this will probably change to Vermont, and then we're looking at Iowa City in November. So it's a way for us to connect with community, not just in our area, but around the country. And then we have our community webinar series, which I definitely encourage you to look at. We have all of them on our YouTube, which you can find on our website. But this is a lot of information focused on the Duchenne community, but what I love about this is we try to make it relevant not just to Duchenne, but other rare diseases. So like our most recent one was, we had a webinar on PJ's protocol, but prior to that we had a physician talking about rhabdomyolysis and what that looks like, why it's dangerous, and how to get treatment. So it's things that we're hearing in the community as needs and trying to bring knowledge to the community based on those needs. So for example, in August, we are planning on having a webinar with Dr. Panda from Arkansas on weekend dosing, because that's a big issue that we hear in the community. So we really do try to keep up with that. Our ambassador program, so Trina was an ambassador, Jessica used to be an ambassador as well, but this is really a program to connect not only newly diagnosed families, but new to the community families as well, to help guide them in their journey. And we try to connect people either in the same stage of their journey or a little bit more advanced, and hopefully in the area that you're in as well, because resources are so dependent on state, county, et cetera, that we want to try to connect families with people who, A, have an understanding of what they're going through, but B, can help guide them in the right direction. We also have our Can't Promise program. So a little bit about me. Prior to being at Jett Foundation, I was a pediatric nurse, but prior to that, I worked for the MDA. So Can't Promise is something that I am super passionate about because we have no age limit, unlike MDA, which ages out at 17 currently. But our Can't Promise is 6 to no age limit. We are actually moving to 7 locations across the country. So we will be in Arizona, Ohio, Colorado, Washington, Pennsylvania, California, and South Carolina. So we will never be as big as MDA, but we are trying to definitely get those pockets of areas for, individuals to be able to attend. All of those serve the 18 plus community, but our Ohio and our Arizona and our Southern California locations are specific to the 18 plus community at this time. One of our other cornerstone programs is our Jett Giving Fund. So we have 3 arms of our Jett Giving Fund at this point in time. We have our Accessible Vehicle Fund, our Emergency Fund, and our Equipment Assistance Fund. So our Accessible Vehicle Fund, the way that works is families will work to raise half or more of the funds of a vehicle, and then Jett Foundation will come in and provide the remaining funds and purchase the vehicle outright for that family, so that there are no monthly payments. The only thing that they would be responsible for is insurance and upkeep and gas after the fact. But one thing I say, and as most people in this room know, accessible vehicles are not a want, they are a need. So the cost of a vehicle is astronomical, so trying to help with the burden of that is the point of this program. So in 2023, we had 53 applications that we received. We were able to accept actually 14 families in our program that year. We are looking at 15 families this year. The average income of the applicants is under $49,000, and this year, I'll speak to this year, we had 11 families that had multiple children with Duchenne. So it is definitely a need, and we are doing our best to fulfill the need as much as we can. So one thing I will say about that as well, it is a once per year application. It will open in October of 2024, and then selections are made in the 2025 year. But our emergency fund, which is something that was born out of COVID, but emergencies don't just happen in COVID. So we decided that this is a program that needed to stay. This is a rolling application. You can apply at any time during the years, but it is a once per year award. If you're denied, you can always reapply, but it's a once per year award. And the things that we see the most are help with mortgage, rent, groceries, utility bills, and then there's an other category. So if there is a family in need, please apply, and we will do what we can to help. And we have a committee that meets on all of these applications so they can see if it fits into that other category. We also have our Equipment Assistance Fund, which is new. Jessica Campbell actually heads up that fund, and this is for small accessibility or medical items that are either not covered by insurance or are partially covered by insurance but too expensive for a family to cover outside of that. So this is a max grant currently of up to $2,500. Again, a rolling application, but that's $2,500 per year, not per lifetime. We do have our awareness days. We just had our Rare Disease Day we're in April, 2 months ago now, February 29th. I do encourage you, if you have not seen that, to give it a watch. That we all agree was our favorite to date. It was extremely uplifting. It was a really good conversation. We had 2 individuals with Duchenne, one caregiver of an adult with Duchenne, and then we had an adult with limb-girdle and an adult with SMA, and then our moderators, who are 2 adults living with Friedreich's ataxia, on that panel. And it was like I said, just a really good conversation. So I encourage you to watch it. It is on our YouTube as well. And then World Duchenne Awareness Day is September 7th. We do events throughout the day each year. This year we will have an in-person component in Massachusetts, but what I will say and what I want everybody to realize is virtual is not going anywhere. And we will still have our educational panel virtually. We will have events throughout the day as well. So virtual is not going anywhere. I feel very passionately about that. So we have boxes that we send out to families so that you can decorate and, raise awareness with us throughout the day. So that's t-shirts, and the box items change every year, but the t-shirts are always different design, but always there. So if you have any questions, please let me know. And then our goal at Jett Foundation is not only direct service programming, but we want to serve the underserved and bridge the gaps in the community. So if there's ever a time where you see a gap, please let me know. Email me, alexa@jettfoundation.org. I can't promise it will happen, but I can at least put it on my notepad to see how we might be able to make it happen in the future. And then we have over 200 new families that engage with us every year. So, our programming and being able to connect families to families is a really important thing for us. And that is it. So with that, I am going to ask first if there are any questions. Perfect. Then I will go. And if you do have any questions, and you think of any questions, I'm here. But I am going to welcome up Miss Becky to talk about Dreams Come True here in Louisiana. All right, and we do have a clicker if you want it.
She's gonna.
There you go. You got it.
I can chew gum and tomorrow I can't. Good morning, everyone. Alexis, thank you for introducing me, and I do have to thank Trina and Johnny for introducing Dreams Come True to the Jett Foundation, and I'm excited to begin working with them and through them for what we do. I want to introduce y'all to our founder, Mr. J.L. Neesmith, and his wife, Miss Judy, heard about a child that had a life-threatening illness, had never had pizza. So they had pizza delivered on a fire truck, escorted by a police car. And what they saw, what it did for this child, they continued reaching out. And 41 years later, we are where we are today. And, just follow your dream. And who do we serve? We are a 501c3, which is a tax write-off. So it's a win-win. You get to claim it on your tax, and we get the funds to help dreams. We are very independent. I get asked many, many times, are you a chapter of some other organization? No, we are the mom and pop organization. We only cover Louisiana. Therefore, all the money stays in Louisiana. So we don't depend on anybody. And we can do exactly what any other foundation like us can do. And what do we do? Well, we grant dreams to Louisiana children between ages 3 and 18 with life-threatening illnesses. Do we make exceptions? Yes. If they're 2.5 years old, and the doctor will write a letter stating he feels the child will not make it to 3, then we grant that dream. And we've done quite a few. And the community. I love this. After we grant the dream, we don't forget about our kids. We don't forget about our families. We stay in touch with them. We have fun things throughout the years. I've made amazing friends like Trina and Johnny. Families get to meet other families. They may have different diagnoses, but everybody is walking that same walk. And we can call on our friends. I can call on Dream Families at midnight, and they're there to help. And they can call me. I'm there to help. So we just become what we call the Dream Family. And we're big. And it's just phenomenal. It really is. And if you ever get a chance, well, Trina and Johnny's a Dream Family. If you ever get to meet others, you'll see what I'm talking about. And I hear a lot of families thank us for what we do, that personal touch. Again, we're the mom and pop. I told Mr. J.L. Neesmith, excuse me, I went to visit him the day before he passed. And I told him that Dreams Come True will always operate on the way he founded it, because they founded it, again, with the mom and pop and the love. Okay, sorry. How do we work? We have an application. It's 2 pages. The parents have to complete 1 page, and the treating physician completes the other. Once it's completed and I get it back, the board reviews it, and then we have a doctor that reviews every application. Sometimes, because I'm not in the medical field, sometimes the diagnosis, we're not too sure. Sometimes our doctor has to contact their doctor. There's more to the diagnosis than what was put on the paper. And trust me, the last thing we want to do is make sure a child gets their dream. So after it's been reviewed and approved, then we contact the family to tell them the good news that the application has been approved, and we set up an interview. We interview the child face to face, and at least one parent has to be with the child. We've had some, like it's just one parent and the child. We've had some where, oh my God, it's a family reunion, but we welcome it. You know, we just love that. Then after the interview and the child decides what he or she wants, then we begin working on it. We do not have a time frame. Sometimes they know in the interview what they want. Sometimes they get back with us. Sometimes they tell us one thing and they change their mind. And as long as we don't spend a penny, you can change your mind as often as you want. And as Vicki knows, it has happened many, many times. We have amazing supporters, and those that donate this amount, it goes to these type of dreams. We have really done a handicapped bathroom. We send the entire family on a trip. It's not just the dream child and one parent. We're a strong advocate to include the entire family as much as we can, because the siblings, the other members of the family, goes through a lot. And here are other types of dreams, these that will donate $5,000. And we've done every one of these. After 40-something years, we've done many types of dreams. The $1,000, we've redone a bedroom shopping spree. Our main popular dream is Disney, of course. And then after that, it's the shopping, especially the teenagers, or they want trips. We've had a few teenagers to go to New York to shop, but it's their dream. Vicki, we interviewed a child, and he wanted to ride in a submarine, and Vicki found it for him. He was paralyzed waist down, but they made an exception, and we understood if something happened, you have to hurry and get off the submarine, but they really made an exception for this child. And of course, he has passed, but it was phenomenal. I didn't think we could do it, but she did. Yes, we make it happen. And where do our funds come from? Strictly, mostly fundraisers and donations. And some of our fundraisers are, can you click? Oh, I changed, okay, I did. The fashion show is my most favorite one. I'm going to tell you why. Dream Kids are the models. They model for local boutiques. And in the fashion show, they walk down the red carpet. And while they walking down the red carpet, we show 4 pictures. 2 of the rough, I called, when they're in the hospital, when they're at their worst part. And the other 2 is their dream. And then everybody gets to see the child all dressed up. And Austin was in our fashion show with his dog. Lafayette Shooters gave the dog a scarf to wear to match Austin's camo outfit. And his sister Aubrey was also in the fashion show. I get around 30 kids. And then at the end of the evening, we get to surprise them. They get to keep what they modeled. So they're so exciting. That's thanks to great supporters. Last week, we had our big golf tournament. Next Saturday, I have the big clay shoot. And all this is how we operate. Then we have, go back, corporate sponsors. If they want to, like for the fashion show, I sell tables, different levels, beginning at $5,000. So that's another way. Some people will just sponsor a dream directly. I have payroll deduction and then recurring deduction. You can go on our webpage and hit the donate button. You can make a one-time donation or you can hit the recurring button. And I have from $5 to $75. Listen, if someone gives us $1, we appreciate, because that's $1 more we have. So there's no set amount. Any amount is appreciated and grateful. Okay. And how do we allocate our funds? Today, I'm very proud to say 80% goes to the kids and 20% goes to operating costs. I'm the only paid employee. I work out of my home because my hours, I work for the parents. Mostly I work after 5, weekends, whatever it takes. We accommodate the families. And 20% is, that's all that's spent for operating costs. You've heard me talk. I'd like for y'all to hear it from a dream mom and her daughter. Will it play? It's a video. Will it play?
That's the whole thing about dreams come true. It's giving hope.
When Dreams Come True asked me what I wanted for my dream, my mind went blank. You could literally pick anything. I was thinking, what's a long-term thing that I could have that would benefit me the most? And I just thought dog, and we found the perfect one.
Dreams Come True is a Louisiana charity that helps fulfill dreams for children fighting life-threatening illnesses.
They want to grant anything you want to come true, and that is amazing.
So for the last 2.5 years, GMFS has been a supporter of Dreams Come True. You know, I think what Dreams Come True does for the child and for the family is allows them to remove themselves for a moment from the challenges that they're facing and getting an opportunity to make a memory and something that they could really cherish and for the rest of their lives.
It's surreal because these people, you never see things like this happening to people like me. Like, I was just a normal teenager and I get diagnosed, and then these wonderful people come into your lives, and it's not even just about the dog. Like, it's them, they're part of my community now.
What attracted me to Dreams Come True Louisiana is that it's a local charity. You get to learn and identify who some of the children are. Maybe they're from your hometown. Maybe you have heard of, you know, their fight from social media. It's just so much more impactful.
Dreams Come True is a really good organization. They have helped so many kids. And it's not even the fact that they give you gifts and they give you what you ask for. It's just that knowing that they care about you. And the people that donate to Dreams Come True, they also care about you.
One of the things that we're evaluating when we're looking at nonprofit organizations, where are those dollars going in the, are they staying in our community? And Dreams Come True Louisiana, all of the money stays here in Louisiana to impact those families and children that are facing life-threatening diseases. And that's really important to us. We don't, certainly a lot of organizations, spread money around the country, but we really want to make sure our dollars stay in the communities that we're operating in.
So financial contributions are important, but also people can volunteer their time and efforts and their talents. Dreams Come True Louisiana has several events throughout the year to raise money, where there's golf tournaments or a fashion show or some type of cook-off. And all of those take a lot of resources, and Dreams Come True of Louisiana only has one person on the payroll, and that's Becky Prejean. So without people supporting Dreams Come True with their time and talents, the number of children that Dreams Come True Louisiana can grant wishes to every year would be very, very limited.
What you do for these kids means the world to them.
It's crazy how much kindness so many people can give you.
From the bottom of my heart, absolutely thank you.
And I do want to share that how we different from other organizations. Well, the fundraiser's one that we involve the kids, but we also have a Christmas party. We mail an invite to every Dream family throughout the state. They reply back stating they're attending and what Santa can get their child. So Santa shops, and we have a private party. We have one in Baton Rouge, one in Lafayette, one in Monroe. I'm trying to reach all the kids. We feed them lunch, we have arts and crafts, and then Santa arrives. But families meet families for the first time because not everyone goes to the same medical institute. Not everyone has the same diagnosis, and I've seen amazing friendships grow. So I thank you for your time. Is there any questions? I'm like a grandmother that likes to brag about her grandkids, and I really tried to stay with my notes today because I love these kids. I try to go to the funerals. I get close to them. Golly, like Mr. JL said, it just zaps you. And if it doesn't zap you, I'm praying for you. Again, we cover the entire state. If you hear of a child with a life-threatening illness, please find us, give them an application. You can go on our website, and our applications are there, or you can send me a message. Are there any questions? Yes. Age range? 3 to 18, and we do make exceptions. I don't know if you heard, if they're 2, 2.5, and the doctor will write a letter stating he feels, then we'll definitely grant the dream. And we go till, if they're 18, we grant the dream. And sometimes we'll sneak in a 19-year-old if they just turned. If I can get the board in a good mood. My heart goes out to every family, and again, we include the entire family, definitely for the dream, and as much as anytime we can. And we invite families when we have fundraisers. I want the supporters to see where their money's going. Yes? It's just one. That's our first question on our application, and we all like that, meaning all the organizations, yeah. Yes.
Is there a time frame within their lifespan? Like, do they have to be like within a certain time frame of life for housing, or is it just any life?
Only God knows when he's bringing them home. So no, it doesn't have to be that severe. No. And we don't have a time frame. Like when we receive an application, listen, I'm holding some of 2 years. There's always some, or they want to wait, especially the cancer kids, they want to wait till the port is out. So we do not have a time frame. Yes. Can you say that again?
You work for an organization that might be able to help with the kids' dream, like say one of them wants to make a movie, and you could help with that.
Oh.
How do we become a part of, how do we start that relationship?
You call me. I can give you my business card, or again, you can go on our website and send me a message, or my email address is becky@dctofla.org, which stands for Dreams Come True of Louisiana. Oh, thank you. Please contact me. We've done all kinds of dreams. It's unbelievable. I thank y'all for your time, and if you think of questions later, again, go on our website and send me a message. Thank y'all. Oh, no, that's not my phone.
All right, we're gonna go ahead and take a 5-minute break just to get up, walk around, go get water, go get coffee, whatever you need to do. So we will come back here at 11:20, so 6 minutes. right, everybody, we're gonna go ahead and get started. I do want to just make note that Miss Becky, at the Christmas party, they give and wrap gifts for all of the siblings, so it's not just for the children. She missed that piece, so I wanted to make sure that everybody knew that, because I think that that is a big piece I think we all realize is sometimes not always thought of as the siblings, so I think that's really an important piece. So with that, I will go ahead and introduce Dr. Tamara Bradford, and I want to thank both Dr. Bradford, Dr. Wallace, and Becky for just being speakers today, because we can't have these without speakers, so thank you so much.
All right, well, good morning. Can everybody hear me? Awesome. Well, thank you so much for having me. This is actually quite an honor. So before I start, I'll just admit I have some confessions. Number one, I hate giving presentations. I do. Unfortunately, in the field that I am, you get voluntasked with doing a ton of them, regardless of whether or not you feel like you're good at it. Some people are just natural. I don't think I'm a natural. I get the heart beating really fast and the GI disturbances and all of that. But I've given enough of these now that I have a little bit of comfort, and I'm gonna follow the key which says just be natural and be yourself and talk about things that you know about. My second confession is I apologize that I haven't been here earlier and I can't stay later. I'm traveling out of the country this evening, but I absolutely, and this has been a horrible, horrible week for us. I was telling my colleague there that we had one of our cardiologists at the Heart Center died suddenly this past weekend, and so it's been a very traumatic week for us at the Heart Center. But I refused to cancel or even think about it, because this population of patients I've been working with since I've been a first-year resident, and they have just imprinted on me in a really special way. Number one, because they're so resilient, and they have a families that, I don't know, are just the go-getters, just very active, very engaged, and it's just one population of patients where the families are just so impactful in these kids' lives. I've just, it's a very small population, but I see it a lot, and I've always admired Duchenne patients and their families throughout my career. So, that being said, hopefully it's not too complicated or convoluted. I tried to make it simple, but my goal is to help you guys understand a little bit about heart failure and just talk a little bit about the medications and some newer things that are out there. Do I just click? Is that okay? So objectives, so just a brief overview of heart failure and what it is in Duchenne. Discuss current therapies of heart failure, describe some newer therapies that have now come on the market, and even some other advanced non-medical therapies. I went in the wrong direction, maybe. Okay, so let's talk a little bit about heart failure. Now, I like to explain to my patients that the heart squeezes and the heart relaxes. And so when it squeezes, that's systole, and when it relaxes, that's diastole. So like you have a systolic blood pressure and a diastolic blood pressure. So the systolic heart failure is when the squeeze is just not really squeezing. It's not doing well. So that's the ventricle does not contract well, and the goal of the heart is to pump oxygenated blood to the body so that your organs get all the oxygen they need so that, they can do the work that they are supposed to do. So heart failure causes patients to feel weak, unwell, and it can also impact your organs. Diastolic heart failure, which can result after long-standing systolic heart failure is not what we typically see, but I decided to put it up here just in case somebody mentions it. So this is just when the ventricle doesn't relax very well, it becomes very stiff, there is backup of blood into the lungs, and so, you know, the heart can't fill up with enough blood to supply to the body. So that's just a general overview. Just remember that heart failure is a big umbrella term that a lot of people throw around, but it's really important for your physician to identify for you what it means for you as a patient, because you can have heart failure with normal function, normal squeeze. You can have heart failure with severely diminished squeeze, and then there's everything in between. So there are all these different variations of what heart failure means, and so it's important when you go to the doctor that they explain to you, hey, this is what your heart function is, or this is where your kid's heart function is, and this is what we're going to do about it if it's actually abnormal. And sometimes you can have both systolic and diastolic heart failure. So I'm going to, hopefully this plays, but it's a really great overview from this organization that we're a part of called Action, and hopefully it works. Oh, maybe I'll do this. Let's see.
Let's explore more about heart failure and what it means for you and your caregivers. The heart is a muscle that pumps blood around your body. Your heart has 4 chambers that are separated into the right and left sides. The right side fills with blood from your body and squeezes to pump blood to your lungs to get oxygen. The left side fills with blood from your lungs and squeezes to pump blood with oxygen to your body. It's important that your heart works right in order for you to grow and feel well. Heart failure can happen when your heart does not fill and squeeze like it should. Heart failure can be caused by many different conditions, like congenital heart disease, cardiomyopathy, myocarditis, and cardiotoxicity from medications. Children with heart failure often struggle with growth, have fast or labored breathing, and are less active and energetic than other kids. Other symptoms of heart failure may look different based on your age. Infants may have trouble feeding, meaning they take longer to feed, need frequent breaks, sweat, or have trouble breathing during feedings. They may also need more naps. Toddlers and children often have a poor appetite, belly pain, nausea, and/or vomiting. They may also tire easily when playing. In addition to these symptoms, older children may not be able to lie flat when sleeping or wake up gasping for air. They may also have swollen feet, ankles, or bellies, or have swelling around their eyes. Your care team is here to help if you have any questions or are worried about your child's heart function.
So Action is an advanced cardiac therapies improving outcomes just network it's a collaboration between all of the children's hospitals in the country, most of them, and some globally as well. And as you probably know, pediatric research is very difficult. And so we translate a lot of adult things into pediatrics for management. However, Action is trying to collaborate and come up with guidelines and protocols that we can use together so that most institutions are doing the same thing when it comes to management of patients. And if we put all that data together, then it's like we're doing our own little research in real time, but without having to do like randomized controlled trials. So it allows us to manage patients and learn and figure out what works best. And so one institution doesn't keep that for themselves, they share it with everybody. So cardiomyopathy, like you saw, so cardiomyopathy, that's heart muscle disease, okay? And that's what happens to the heart with Duchenne. Some patients are at risk for getting cardiomyopathy. Usually it's a dilated cardiomyopathy, so the heart stretches out and becomes very dilated and doesn't squeeze very well. Similar as the skeletal muscle weakness progresses, a similar phenomenon happens with the cardiac muscle. And this is just a visual of what happens to the left pump-in chamber when patients develop a cardiomyopathy. And what kind of cardiologist would I be if I didn't have some echo images? I promise this is just for comparison to show you what we see on echo, because I don't know how much you see and understand. You know, your kids and relatives might be getting ultrasounds all the time, but what are we looking at? So pray for me that this plays. Maybe. I think I went up. Okay. I can't get it to play. Do you know? Yeah. Is there like a right click maybe?
Are you sure that it is?
They are, yeah. I mean, and they played. I checked them playing like multiple times, but there's a thing that's supposed to come up,
Right.
but it won't. Like, I don't see the.
I'm sorry.
Oh, it's okay. Okay, so what is supposed to be shown here is this is a apical four-chamber view of the heart, and this one is nice because you can actually see the four chambers, so the two top chambers and the two bottom chambers. So this view is most consistent with what we conceptually know as a heart, and this would be your right pump-in chamber, and this would be your left pump-in chamber. And so if you can hallucinate with me, you can see that this chamber is what we would consider normal, but over here, this chamber is pretty stretched out and dilated, and the walls are a little bit thin. So if this would play, you would see that this one isn't squeezing very well, and you would be able to see that the contraction on this one is very good. So I do apologize that the videos aren't working. And these are just different images showing similar things, like what normal should look like and what a heart with dilation would look like. And then again, a different image, so hopefully you can tell the difference in size, at least, in the LV pump-in chamber. So symptoms associated with heart failure, and the video kind of alluded to this. So definitely poor growth. Now I will say that most symptoms of heart failure occur when patients have severe dysfunction. So I could say that your function is mildly diminished or moderately diminished or severely diminished. We like to quantify things, right? It helps us understand better. And so the ejection fraction, which I hope many of you are familiar with, is what we use as a quantifying measure to say this is what your heart function is. And it's, it's a number, but we kind of give ranges to the numbers. So if your function is greater than 55%, that's normal, and that's where you want to be, because that's what normal is. When you start falling below 55%, that's when we say your function is diminished, it's decreased, you have heart failure, it's not squeezing well. And so, 45 to 55% range, that's mild. That's mildly diminished. And you could be there and you could never know. You would never know. You could be less than 45% and above 35, and that's our moderately diminished range. Patients that are less than 35 to 30, that's what we would say is our severely diminished range. Okay, and that's where we would typically start to see symptoms, but not with everybody. And the goal of heart failure therapy is to help you maintain your quality of life without knowing that your heart function is diminished. That's the goal. And also protect your heart muscle from getting worse or delay the process of it getting worse over time. So symptoms, poor growth, when the heart muscle is weak, it has a risk of the electricity doing abnormal things. The heart has the structure, which we saw, but there's electricity in the heart, and that electricity, when the muscle is weak and not doing well, it means the cells are injured, and that means the electricity can also do crazy things. When the heart gets stretched out, it can cause leakiness of the heart valves because it pulls, the annulus and makes it bigger. Kidney disease, because of blood flow to the kidney, the blood flow to the kidneys gets compromised, it gets diminished. Liver disease is the same thing. It's not intrinsic liver disease and kidney disease. This is because of poor cardiac output. These tend to happen, again, severely diminished if you're not well controlled on medical therapy. But so these are if heart failure gets really bad and you become not compensated. And then blood clots. So aspirin might be something that we put patients on when the function gets to be severely diminished because blood likes to clot. And when you have a big LV that's not squeezing well, that's like waiting for clots to happen. So let's talk about the current therapies that you guys might be familiar with. And so we throw a lot of words around sometimes in abbreviations, and so I just want to make sure that everybody's aware of what we didn't just pull them out of the sky, where do they come from, what does it mean? So the mainstay are going to be your ACE inhibitors or angiotensin receptor blockers, so ACEs and ARBs, and beta blockers. There's some adjunctive therapies, but these are going to be the primary heart muscle influencers. So it could be any number of these medications. There's a whole lot of them out there. These are the most common ones. Captopril, not so much usually because that's a 3 times a day, and who wants to have to give a kid a medication 3 times a day? And then carvedilol, metoprolol, atenolol. Let's see, so how do they work? So I'm not going to get into physiology of kidneys and how these medications work, but basically they help the blood vessels relax, they improve the blood pressure, and they reduce the need for hospitalization and improve survival. And this is information and data we really get from adult patients that have heart failure that we've then translated into pediatric patients that have heart failure. So we decrease the stress on the one. The way I like to explain it to families is I say, if you have high blood pressure or even normal blood pressure, the weaker your heart muscle, the harder it is to pump against that blood pressure. So blood pressure medications work well because they lower your blood pressure and they allow the heart muscle to not have to work that hard. So that's the overall concept of why blood pressure medications work. So why is my 12-year-old on the same medication that my 70-year-old grandparent is on, And then the beta blockers help to slow the heart down. And this is beneficial because your heart's gonna pump at a slower rate, but it is going to give your body the same cardiac output that it needs. So in essence, it's doing less work, right? And in the long term, we think these medications together help to protect the heart muscle, or at least delay progression and protect the heart muscle cells from further injury or slow down injury. Beta blocker is also good because Duchenne patients tend to have a dysautonomia where their heart rate tends to run higher, and that gets worse as they get older. So beta blockers help to control that. And if they have arrhythmias or abnormal heart rhythms, the beta blockers can also be used to treat that. So beta blockers are very beneficial in this population. And then additional therapies depending on where you are on severity, some diuretics like Lasix, Diurel, and then aldactone or spironolactone has really come on the market now to be used as an anti-mineralocorticoid for anti-fibrosis. So a lot of families, if you've had a cardiac MRI, we know that your heart muscle has scar or fibrosis in these patients. And that actually develops way before we start seeing changes in the heart muscle. And so in some families, some of the conversations that we have is, between the ages of 5 and 8, do I really want to start my kid on a medication? No. But we have the conversation because knowing what the natural history of the heart disease is in this population, these medications, if initiated early enough, can be beneficial in some. Aldactone is another one that we can add to help with that as well. You have to watch your potassiums in that, so we do sometimes have to get labs, but that's what it comes from. So the newer therapies which have come on the market, so the ARNIs, which is the angiotensin receptor, so kind of like a cousin that we saw, the angiotensin receptor blocker and neprilysin inhibitor, so it's called an ARNI. And so the biggest one on the market is Entresto, and it's a combination of valsartan and a neprilysin inhibitor is what it is. And what we think is happening there, that's just taking the benefit of lisinopril or losartan and, well, not lisinopril, but a cousin of lisinopril, and just combining it together to get a better impact. We don't have data in pediatrics that, this helps. This data, again, comes from adults, mainly adults that had, MIs or heart attacks, and then they end up in heart failure, and then they put them on these medications. And it's also been shown to be beneficial for patients with kidney disease as well. And then the SGLT2 inhibitors are, I'm not even going to try to say that word either, but look at all these fancy words over here, which are the, the names, and then these are the brands. So Jardiance and Farxiga are the more common ones that we see prescribed. These are actually diabetic medications originally, and so they help to lower blood sugars because they work in the kidneys, and they help you to pee glucose out of your body so that it doesn't stay in your bloodstream and your blood sugars don't get high. But what they found and why it's been beneficial is that what they noticed is that it helped patients in these big studies. It also helped patients with chronic kidney disease, which diabetics tend to have, but also had heart failure. So it helped to protect the kidneys in addition to helping with heart failure. And so that was not an expected outcome. This was something that they found, which is why these studies are important. It's just our population in pediatrics tends to be small, so we can't do these ourselves. So you do a big randomized control study, and you're focused on one question, and you answer that question, but then the data shows you that, either there are things that are not good, or there are additional things that are helpful for other diseases. The biggest one that I can think of is Viagra. That was actually a side effect. That was not what it was originally studied for. And so, but it came out to have a beneficial effect in a different organ system, and so, we're able to use it for multiple uses, which is really good. So I would say these two are the newer ones. I did talk about a little, so the side effects, which is obviously very important. So low blood pressure, dizziness, I would say the Entresto, that's the biggest complication that we tend to see with it, is low blood pressure. And dizziness is usually the biggest manifestation of that. Blood pressures can be low, and it is very concerning depending on the situation. But for us, when we're thinking about protecting the heart muscle, we want low blood pressures as low as the patient can tolerate, but without being symptomatic with like dizziness and lightheadedness. And so a number, a patient might have a blood pressure of 90/60, which might be super low or concerning for somebody who's used to running around at 130. But if they're maintaining their daily activities without a problem, then, 90/60 works for them, so I'm not concerned about that. So having that discussion with families is also important, because sometimes, I know a lot of Duchenne patients, they do tend to have a lower blood pressure, which can be concerning. So it's kind of, hey, let's try this, but if it doesn't work, you let us know, we can decrease the dose or switch to something else. So it's usually a conversation between your physician team and, as a family. Potassium in the blood, so the aldactone, ACEs, ARBs, so that's your losartan, lisinopril. Beta blockers are known to cause fatigue. Usually in the first couple of weeks, as the body gets used to it, that tends to get better. Kidney problems, ACE, ARBs, ARNIs, SGLT2 inhibitors, anaphylaxis, beta blockers, lisinopril, and these are obviously, this is very rare. Angioedema with lisinopril, very rare, but it doesn't mean you can't use a cousin of lisinopril or a sister, so it just depends. And then cough, lisinopril and carvedilol, and then UTIs. Because you spill glucose in your urine, the risk of UTIs goes up with SGLT2 inhibitors, so it's just something to be aware of. And then destination devices, right? So the era has kind of shifted in the last decade to where we're saying, you know, if these patients have an otherwise really good quality of life and their heart muscle is weak, we think, especially in patients that are, the heart muscle is weak early on, like early onset, then devices are something that we can also offer to families. The HeartMate 3 is the one that's offered, and obviously you have to be a certain size to be able to get it implanted. And we call it an LVAD, which is a left ventricular assist device. It's surgically placed that helps the left ventricle pump blood to the body as that muscle gets severely diminished. It is a lifelong implant and a lifelong option, so that is not to be taken lightly, obviously very invasive. So selection for this is, you know, about candidacy is, you know, it's very selective because you have to work with a big team of people and the family have to be ready and prepared and committed to do this. But I have interacted with families that have done this, and in the right setting, in the right setting for the right family, this can be an option. I don't know if this is going to work because I've not had success, but let's see. Oh, control. Are we connected to the internet or no? I may not have success, but all my stuff worked on my desktop, but is that it? Okay. Yeah, and these are just like 1-minute videos.
Your HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta, the main artery feeding blood to the entire body. The pump helps your heart by taking over the work of your left ventricle and pumping oxygen-rich blood to the body. The pump is made mostly of titanium. A small electric motor inside the HeartMate 3 drives the pump, providing blood flow similar to a healthy heart. Although the HeartMate 3 LVAD is virtually silent, it is normal to sometimes feel the pump working. To power the pump, a tube called the driveline passes from the LVAD through the skin in your abdomen. The driveline consists of 2 cables, the pump cable and the modular cable. One end of the pump cable is connected to the pump, the other end exits your body. The modular cable connects to the pump cable at the modular inline connector, and the other end connects to the system controller.
That's it?
I think I'm gonna start cutting carbs.
Your HeartMate 3 heart pump is...
I guess you can close it, yeah. No.
Your HeartMate 3 heart pump is a left
You can
ventricular...
close out of it. Yeah. There it is.
You
Okay.
need the other one?
No, we're good, yeah. If you guys wanted to see more, I had another video, but, okay.
Sorry.
Yeah, that's okay. Great, so that's just a little brief overview of what it is. Now, again, obviously, every patient doesn't, isn't great for a VAD, but it is an option for some families. The other thing is, it requires a very intense team to take care of these patients. Like you saw the device, the only thing that exits the body is the one little line. But of course, their respiratory status, all of these things play a role. So it just depends on how sick the patient is, what other associated issues they have going on. And it requires rehab and all of that. So very intensive, but I have sent patients home with these. It's not a lot, but the families that do commit to it and do want to do it, obviously that's a decision that they made for themselves, and it's, it works for them. Let's see. And then several pediatric LVAD centers, in the country. Like I said, not a lot of centers do destination VADs in muscular dystrophy patients, but it is possible, it is out there, and so I think you guys should know about it. Just be aware of what's, out there for this population. And then transplant, believe it or not, I have interacted with 2 transplanted patients with Duchenne. Both patients had really severe heart failure at a young age, so less than 10 years of age, and were still ambulatory. And so transplant obviously comes with its own set of issues. However, when heart failure occurs that early, that is really early, even for a Duchenne patient, knowing that their lifespan is expected to be a little bit shorter than is normal. However, transplant can be used as an option. I'm using my hands a lot here. In some patients, if it occurs really early. So both patients were 8 years old and had really severe dysfunction, that's atypical, right? And so it required an atypical response, usually, and I would say transplant for a Duchenne patient is usually atypical. But the half-life of a transplant is about 12 to 15 years. And so if you think about it, transplanted Duchenne patient at 8 years old makes sense because that's still within their expected lifespan. So again, it's very rare, but a possibility for patients that have an atypical presentation of really early onset heart failure from Duchenne. So here are most of my resources for today. And then I just want to say thank you for having me. Hopefully this wasn't just like dogged with a lot of medical stuff. I really apologize, but I don't know how to do anything different. And it's just really important to me that patients and families understand what's going on with the heart in these patients and the options that are there and why things work for some patients, why it's better to do other things for some patients, and just understanding the medications, why we do what we do, because sometimes it feels like you come in and it might be like, oh, we're doing this and we're doing this and we're doing this, but having the background, I think, is important because I think it helps you guys trust us more and it helps us to build that relationship as we take care of these patients. So we should definitely try to do our best to move from heart failure to heart success in these patients. And that's all I have. Questions? Yes?
I'm sorry, this might seem like an obvious answer, but
No.
you said most of the children's hospitals don't do destination VADs. What does that mean?
So that means that, the VAD is the device, destination meaning that is the end point. So we put the VAD in, and because usually when we say we put in a VAD, VADs were usually used or traditionally, as a bridge to transplant. However, in certain populations, we found that, hey, you could keep a VAD for years, so why not offer it to populations that are not typically transplant patients, right? And so in that case, it would become their destination to help them maintain a quality of life without the heart being the reason for them to have an early death because of severe heart failure. So then in those situations, it would be destination. And we do it in the adult population as well. And actually, some older people in the 70s and stuff, 60s, they decide they really like their device and they don't want to go to transplant. We've actually have some families decide that. So, because they do work and they work well. Obviously, the surgical procedure and the rehab and getting home is a big deal, but once that happens, most patients do really well. So it's called destination for that reason. No, yeah. No, so the rehab part will be after the immediate postoperative period, making sure that the patient gets back to baseline activity, whatever that was for them. Once they get back to their baseline, yeah. So the goal, like with any surgery, for any patient, it's you come in, you have your surgery, and then how do we know when to send you home? It's when you get back to a baseline that's, consistent. Can you eat? Are you sleeping well? Is your pain controlled? Are you able to move and do all the things that you were able to do before? So once you meet those goals, then yes, then usually they don't have any problems after that. Obviously, respiratory issues can also be a big deal in Duchenne. So the more complex that your respiratory needs are, that then makes you a more high risk and complicated patient. So that's why it's a big evaluation that has to be undergone, and not everybody is a candidate, but it's a discussion that has to happen between you and your care team. To determine whether or not your child, whether or not your child, would be a candidate. Hi. Yeah. Mm-hmm. Yeah. It depends. So losartan, we think, also has some anti-fibrotic or anti-scar properties. So like your son, I'm sure when he had his MRI, I'm hoping that the squeeze was normal and everything was fine, but there might have been the presence of scar or fibrosis. So that's something that we use to talk to families about. So there is injury going on to the heart muscle. It's already gone on, otherwise there would not be scar. That's what the scar means. And so for us, it makes us want to be aggressive because we can see what severe heart failure can do to some of these patients. And we don't know, I can't tell you in a patient at 8 or 10 what kind of cardiac prognosis or journey he's going to have. But if you have scar, I want to protect that heart muscle for as long as possible. So I would talk to you about starting medication. And so losartan would be a good one because it's blood pressure, it does all of the heart muscle, but it's also better than lisinopril, I think, a little bit, because we think it also has some anti-fibrotic and anti-scar properties. So the aldactone, I would say that would be added usually if you already start to have dysfunction. Not like if your function is normal, your squeeze is normal, you just have scar. I would advocate for starting something, but aldactone by itself, I wouldn't just add, because the beta blocker and, like we said, the ARB and the ACE are really the primary medications we want to start first initially. The aldactone would be like an additive or an adjunctive medication later on if we start to see other changes.
So in your opinion, by doing the biannual MRIs, that'll help determine?
Yeah, the amount of scar and if it's progressing. Yeah. You're welcome. And we usually wait until 8 to 12 because it depends on the maturity of the patient to be able to lay in the scanner and get the images, because I don't want to sedate kids to have to get an MRI. So we usually wait. So we start talking to families around, start bringing up the medication thing at 5. Some families are ready for it. Some families are like, no, and we'll just wait till we get the MRI and see if there's scar present. And we usually wait till about 8 to 10, 12, depending on the maturity of the patient, because you want to get it while they're still ambulatory. It's just easier. And that's just mechanics, because we're trying to think of, trying to get, a patient that has lost their ambulation is a little bit more difficult for families. And to be honest, once you see scar and you maybe have one follow-up and you see it's progressed or it's not progressed, the scar is present, you know that the damage has already started. So I don't, so we can continue getting MRIs, but I think as the patients get older, it becomes a little bit more cumbersome and difficult for families. So I just stop after the first couple. But that's not because we can't. We definitely can, but just because we can doesn't mean we should. We already have the information that we need. Yeah, and that's why I like Duchenne families, because you guys come in gung-ho and ready to like do whatever it takes. And now we have this, I think like new drug that just came out, and it's for young kids. I think it's one dose. It's this new drug that just came out for Duchenne, and it's given, I think, at 4 or 5 years old. It's one infusion. There's some cardiac side effects that they have to watch for. I think we had one patient start on it at Children's so far that did okay, but this is what it should be, right? There should be ongoing research, and we should be promoting that for this population of patients. It's just really important. Hey. Yeah. So I actually have several that we follow. When I trained, I think it was the first time, and I'm not going to age myself here, but it's been let me see, I'll just be honest. I did fellowship from 2010 to 2013, and I did my fellowship at Cincinnati Children's, and then I did a 4th year in heart failure transplant. So during that time, I think it was becoming more knowledgeable. And because of who my mentor was at the time, he was just super heart failure, cardiomyopathy. And so he just really trained us up to really take good care of these patients. And that was the first time that I was made aware of girls and moms who are carriers that can be affected. So if anybody's familiar with Cincinnati Children's, then they follow these patients, and a lot of other programs now have like clinics and stuff, but yes, absolutely. There are a couple of patients that I follow that have what I would consider really early presentation of cardiac manifestations of being carriers, but that's why they need to be followed. Moms, having that conversation. A lot of moms of parents that I follow have never been evaluated by a cardiologist, so it's the first time that they're having this conversation. And so education is really important so that families are aware that it's not just your young sons that are affected. This is like my nemesis now. It's not just young sons that are affected, but moms and carrier girls can also be impacted, and they need to be screened and monitored just like the Duchenne patients. So yes, I have seen it. I only have 2 that are symptomatic from a cardiac standpoint. And I would say that it's early because they're teenagers. But yeah, so whatever they manifest with, I manage and I treat. I don't disregard because you're a girl carrier of Duchenne. So, if you have rhythm stuff, we take care of that. If you have function stuff, we treat it the same way. Good, good. Informative, hopefully not boring. I don't know how to, I did my best to spice it up.
So my question is more of a logistical question.
Uh-huh.
I don't know if you can answer, or anyone here might chime in with it. And I haven't had like a specific conversation with my sister, but thought
Uh-huh.
might come to me from time to time. Like, she travels relatively frequently, I think, to Arkansas to go see specialists, the doctors that she wants her to
Uh-huh.
keep her son off.
Arkansas Children's? Okay. I was there for 5 years before I was recruited here.
So it's a long drive.
Yeah.
She hits the road, and she has to get, these MRIs and testing, and then go back to the appointments to review. And I just wonder if there are options for like partnerships with some of these, the institutions where the great specialists are, to be, for her to be able to get her MRI locally and have them review it rather than her having to go back and forth to get testing and then get the review. Like, can't you just read the MRI?
Yeah, so it's because the MRI will be read by like a cardiac radiologist. But I'll tell you, she can just come to Children's and I'll see her. Yeah. Children's Hospital here. Yeah. We do cardiac MRIs. I follow.
She wants to see his doctors in Arkansas. And so I'm just, can there be partnerships? Some understand.
Yeah, so that becomes complicated. It could be that she just gets scheduled for an outpatient MRI here and the result is sent to the doctor if that makes it convenient for her. And that way, but not a lot, but sometimes, and you can have that conversation, right? So are you seeing who, Dr. Connect or? Oh, Cindy. Yeah, I worked with Cindy. It's a gentleman with glasses. Yeah. Younger. Okay, one of the young. Okay. So it just depends. So, yes, she can absolutely get her study here, but it would be a conversation for you because you have to make sure that your family and your care team are on the same page. So if you say, hey, it's really inconvenient for me, is there any way I can get my MRI locally and have the result and the images sent to you? That's definitely doable. So yes, they kind of line everything up and thus far, yeah. And we try to, because even there, like every institution, right, whatever the family needs, whatever barriers they have, whatever we can do to make it more convenient. I know sometimes it doesn't seem like that, but we do think about families in that way. Families that like, hey, my insurance doesn't pay when I get labs at Children's, right? So give me the prescription and I'll go locally and get it. And that works too. And if you're coming for another appointment and you don't want to come back, for a special cardiology visit. Sometimes I open up days on special days just to see families. Here, we have a multidisciplinary neuromuscular clinic, and so, families just come upstairs when they finish with neuromuscular and they come see me in cardiology. It's hard because I need a sonographer to do the echo, and so that's why I don't go down, but, at least they can get everything done in one day as opposed to coming so whatever families need. So if you need that in the future, you ask if they would be willing to let you do that, and then it would just be an outpatient order, and you come in and you get it, and then the results can be sent there. So it's definitely possible. It just requires a conversation. Yes? I haven't started any statins in Duchenne patients. I haven't had to. I guess the typical screening for hyperlipidemia starts a little bit later. And it's usually like a PCP well-child visit, unless there's a strong family history of like early heart attacks, less than like before age 40 or before age 50, and really high risk of high cholesterol. So typically, they would just be screened on the usual for every pediatric patient, which I don't know if that's like 18 years of age. You get like, some families come to me, they don't have Duchenne, but they come for hyperlipidemia specifically because they have a family history of like a mutation that causes super, super high cholesterol at a young age. But I would say they could just usually get the whatever's normal screening for lipids at whatever age that is. Now I know some patients are on steroids and that can have issues. And so that's a discussion, I think, with neuro, how long they've been on steroids. And, it's probably worth it if you've been on steroids a while, just to at least get screening and then go from there. Because some, long-standing steroids can be a problem. Although there's also a new Valmarone, a new steroid medication. I'm sorry, they're not cardiac medications, but I know of them. So we'll see. So that could also be beneficial with less side effects. So we'll see. All right. Well, thank you guys so much.
Wonderful. Okay, we're going to take another 5-minute break. We will come back at, we'll do a little bit more than 5 minutes. We'll come back at 12:25, and then we will have Dr. Wallace speak. So if you have any other questions, Dr. Bradford will be leaving shortly after, but if you want to touch base with her real quick before she heads out, please do so. I know some people don't want to ask questions at the podium, so please feel free to connect with her now. Thank you, guys. All right.
Do you have to do something to get this right?
Technically, I don't think you have to, but... Maybe. See, it's not just you. All right, we're going to go ahead and get started. I would like to welcome Dr. Becca Wallace up, and if you have any questions, she'll answer them.
Hey everybody, thank you for having me today. Let's see if I can use technology. To start out, well, before I even get there, my name is Dr. Becca Wallace. I am a pediatric psychologist based out of Children's Hospital, and I work with a lot of different medical conditions, but one of my favorite is my neuromuscular, especially my Duchenne patients, because it's kind of like Dr. Bradford said. I love how resilient the families are, everything they go through and overcome, and just how they're able to really appreciate life and make the most out of life. So today I'm talking about what about everybody else? So I think something that happens a lot with a lot of our medical populations is all the doctor's appointment, all the attention is focused on, the affected child. And not many people stop and say, hey, mom, dad, aunt, uncle, how are you doing with it? How are the other siblings? Like, we know everything about this child, but we don't know, like, the cool sports and activities that the siblings do or who they are. So I'm just talking about that a little bit today. So I do want to put a disclaimer. I don't have a child with Duchenne's. I don't live your story every day. And the information that I'm presenting, we don't talk about a lot because it's kind of sensitive, and not by kind of, it is really sensitive. And I get that some of the stuff I say might not apply to you at all, or you might be like, yes, this all applies to me. And it's very subjective. So please, the information I'm giving you today is based off my experience with families, what I've researched, what I've learned. And I really always try to learn from families and get more out of them than even I get them, to help them figure out what their story is. So I'm going to be talking a little bit about just caregivers and mental health, siblings, and just stress management for the family, how we deal with all of this. I have a lot of information because I always love to share too much information, and so don't be surprised if I start talking 100 miles per minute, trying to cram it all in. So when you have any child, you're not just a parent. You become a lot of things. And when you have a child with Duchenne's or another medical condition like it, that becomes even more true. You are the parent. You have to do normal parenting stuff. You also have to be an advocate. You're always having to call the school, call the doctors, call the congressperson, the pharmacy company, the insurance company. You're always having to advocate and fight for your child. You're also their healthcare provider. You have to be part of the team. You have to talk to the doctors and nurses and understand all the medical jargon and do the home treatments. We're not the ones that are there giving the medicine, every day. We're not the ones doing the breathing treatment and the night treatment and setting up G-tubes or whatever. You have to be a healthcare provider, whether that was the career path you wanted or not. You have to be an educator sometimes. You have to know about the education system, 504, IEP, how to fight that. When you decide, or if you decide for your child to be homeschooled, you have to be a teacher. Keep them on track. How do we teach them? Even if your child does go to school, you still have to you have to know enough about education to keep it up. You also sometimes have to be your child's friend, because it's a little harder for them, especially when they get to this stage where, getting around's a little harder and they're in a wheelchair and not every place is handicap accessible. You have to have fun with them. You want to have activities. And I am sure there are a million more roles that I'm not even listing here. But all that to say is it's a lot for one or two people to kind of be. And when we look at, different stresses going on with Duchenne, you kind of like I did with the whole things is, medical, you have to balance doctor's appointments and home medical treatments and some really complex treatments. Again, I don't think every parent decided to get,
to go to med school and learn all of these things. So you kind of have to learn it on the mean streets of med school, meaning like you're learning it as you do it. You have to coordinate with DMEs and insurances and, getting meds. And then if we go in the hospital, how do we get to the hospital? How far do we have to travel? Where do we stay while we're there? Who watches my other kids while I'm there? That kind of goes into financial of transportation, talking about driving to Arkansas. Like, you have to have gas. You have to make sure your car has the oil change. You have to make sure you can make it. You have to make sure you have a handicap accessible vehicle to get there. There's a lot of medical expenses that are out of pocket that you have to figure out how to cover. And you also have to work to be able to afford this, but have sick days and flexibility to take off work to take your kids to all these appointments. And pay all the activities and keep them entertained, because the typical things are harder to do, or it's harder to get to vacation spots that are handicap accessible, and there are extra costs sometimes. But then just even the emotional toll of unfortunately Duchenne's is a condition that the child declines as they enter really into the stage that you want them to be independent, and watching that is heartbreaking. No parent ever thinks they're going to have a child and have to watch their child go through what you have to watch your child go through. And I always say that a parent feels these situations threefold. So you feel it as a parent, and you feel it personally, but then you feel everything your child goes through, and so you feel it that way. And then you feel it also as a family unit. And so it's kind of your parent heart just explodes, because it doesn't know what to do with having to cope with all these emotions in a complex way. But it's also isolating, your community might not have another kid who's going through the same thing you are. And they don't understand, and they don't know how to include your child. And you don't want their sympathy and pity, but they don't know how to just be normal. But then you also have to balance your whole family's mental health, the other kids, your child going through this who's having their own coping with it, and then kind of your personal mental health on top of that. And now if you're not overwhelmed from those three categories, we also have this social of like I said, finding disability-friendly locations. Even some of the parents I talk to when we do our multidisciplinary neuromuscular clinic, they struggle because they're getting here and getting the hotel, and their hotel isn't handicap accessible. And I've had parents that have even pulled up to one of the local Ronald McDonald houses, and they can't get their child into the Ronald McDonald because the curb and the stairs, and there's no handicap accessible, which blew my mind. But little things like that, or they don't have the lift, they don't have the, they don't want to bring a U-Haul every time they come, and so that's a lot. Or they want to go on family vacation, but it's so overwhelming to do that it creates more stress, so we stop going on vacation. Or, they want to go to theme parks and stuff like that, but you have to find one that's going to work for that child, and it makes it a lot more stress than it should be. So something fun becomes stressful. And like I said, figuring out education and that support, not only for you, but also for your child. All of these things are going on. And again, I'm sure I could ask around this room, and there's probably things that I don't even know about that go on. And so when we really look at it, it's not surprising is, caregivers who have a child with Duchenne, they are at higher risk of depression. And they've actually shown that as the child passes the age of 13, that risk for depression in the parent gets larger, mainly because the child really at that age starts to have more limitations. And when we have families that really have that social isolation and they feel like they don't have anyone to connect to, that risk increases even more. And then when we go through, I hate to bring it up, but pandemics, and you don't want your child to get sick, it creates the isolation even more. And then people don't know how to reintegrate you back in. And there's also a higher risk for family conflict and discord when you have a child with a medical condition. We always, kind of in my field, we say these situations and medical conditions, they either make or break families. And it's kind of a situation, and there's no rhyme or reason, but it really kind of just determines if the family is gonna pull together and husband and wife or whatever the family dynamic is, whether they're going to work together to support their family and keep it going, or if they need to work separately. I know some amazing families out there that, you know, the two parents are no longer together, but they have such a co-parenting team, including step-parents, that are able to support that child, and they do better separate than together. But it really makes you decide, are we going to cope with this together or separate? But it also can bring families together in a beautiful way. There's higher risk of stress and anxiety, because I listed all of those things and more. But also, we have, as children advance in their condition, you have to have more interventions. You have to figure out, you know, how to use a power wheelchair, how to make sure it's always charged. Like, what do we do if it dies in the middle of Walmart? You know, we might have a ventilator added on. You know, if we have the VAD device, like, how do we manage that? What does that look like? What happens if it starts beeping at 3 a.m.? You know, if we have G-tube, how do we manage that? All of these things, again, you didn't go to medical school. You didn't want to necessarily be a nurse, or you did, and that's amazing, and you learn it anyway. It also leads to lower self-esteem. A lot of parents, you know, you have that guilt of, how did I give this to my child? What did I do for God to curse me with this, to give it to my child? Why this child? And, you know, you feel guilty about that, even though it's not something you can control. Sometimes it runs in families for generations before we see it. And just I always make a joke about, like, crappy genes. You could have just given me gap genes. You didn't have to give me these genes. You know, there's a higher instance of grief. You miss out. You're grieving those experiences that, you know, you never got with your child. When you're holding a fresh, beautiful baby in the hospital, you picture, you know, kindergarten graduation and, you know, angsty teenagers and 16 driving a car and 18 and weddings and all this thing, and you kind of have, that's not how life might go. Like, we might never get to drive a car. You know, you grieve the process. You grieve on the life that you thought you had, and you might have way better, more beautiful life, but it's just not what you expected. And it does show that when we have complex medical conditions like Duchenne's, there is that lower life enjoyment because there is so much stress with every experience. That said, there's a caveat to that. But a lot of times that can happen, and then you're at higher risk of limited parenting. So a lot of times when our kids have medical conditions, like, as parents, because of that guilt and that grief and overwhelm, we kind of let kids get away with more. And then sometimes, you know, we don't set limits with them. And then when we don't push them quite as much as we might have pushed our other child, or if the situation was different. And so sometimes we end up with, like, these behavioral issues because kids are going through it themselves as well. So they might have their own depression and grief and anger, and parents feel helpless. They feel like they can't control their child because the real ages where we would have, like, established those clear boundaries aren't there anymore. And this is natural. I mean, we joke at the hospital that sometimes, like, we unintentionally create monsters because they come in and we want it to be nice because we don't want the hospital to be miserable. So we have, you know, fun and games and gifts, and we give them everything. And you want ice cream 4 times a day? Cool, here it is. And then we send them home to you as parents and say, okay, good luck, parent them, have fun, send them to school, make them do their homework. Like, it makes life miserable for you. I'm not gonna lie, I'm sorry. I'm the evil one that comes over and I'm like, your child needs to do school here, make them go to bed. But all of these things makes the mental health side a lot harder. So caregiver fatigue is defined as a state of emotional, physical, mental exhaustion that happens when you're taking care of someone else. And so with this kind of working in healthcare, we definitely, and I think this is true of being a parent in healthcare, is it's not a matter of if you're gonna get this, it's when you're gonna get it. Like, everyone in this room who has ever been a caregiver is gonna have it. And it doesn't mean you say, oh, can't be a caregiver anymore, like, good luck, kid, you're on your own. It's how do we recognize it and reduce it when it happens, and how do we address it when it happens? And it's not a bad thing to happen. You are not a bad parent. You're not a bad caregiver if it happens. It's because it's gonna happen. It's recognizing it and making sure that we're doing what we can to support ourselves and support our family through it. And so one of the reasons you're at high risk with DMD is it is a lifelong caregiving that will increase with age rather than decrease. And this kind of goes against parenting, is again, your friends and neighbors and people who might have a child with no medical condition, as their child enters adolescence and young adult, they have to do less for their child. They're like praying for them to get their driver's license so they can be their errand kid of like, hey, you're gonna do all this on your own. But it's the opposite for you. So you kind of don't really have that support to be like, yeah, I can't, like, he's really good with his wheelchair, but I can't send him down to Walmart to get groceries. Like, I would get arrested, right? And also medical care is really technical. Again, you get that medical degree that you never wanted. And just even the physicality required, even with all of the lifts and wheelchairs and moving devices, like you as parents, y'all have like muscles of steel. It's like it's strength that I don't know where y'all get it, and it is beautiful. But like you still have to like lift up your child and move your child and move their legs and move their devices and push their wheelchairs when they die. And so that's gonna take a toll on its body. And as caregivers, and again, this is true in the medical field, we're not always great at taking care of our own health behaviors. So we have 3 main energy sources, which I think I'm also gonna talk about later. So this is a preview, but like eating, sleeping, and drinking water. You know, how many times when like your child's sick or you're going to all these doctor's appointments, do you make sure that you have breakfast or have eaten lunch or have gone to the bathroom? And you know, when your kid is up all night and can't sleep, who's sitting right next to them, not sleeping with them? And you know, again, when your child gets older, you think you can get more sleep because you got out of that baby stage, but that's not always the case. And so when we're not taking care of ourselves, it leads to us being fatigued a lot easier. And your life ultimately is about your child or about someone else. And again, that's not necessarily how we expect things to go. Is yes, our children are so important to us. However, we don't think about our life revolving around them. In some of families with Duchenne, the whole family's life revolves around the child. And while that's beautiful, it's also really hard and stressful. So kind of like looking at this as an example is most parents, and I think I could probably add like 20 layers between like the caregiver and self and like child with Duchenne, but everything comes before you. And I think this just kind of shows that like the other thing about it is the world doesn't stop. It's not like you just have to take care of your child with Duchenne. You might have to take care of other children. I have a family I work with that a family member just had a spinal cord injury, so who do you think the family thought the best caregiver for that patient was? It was the parent of the kid with Duchenne's. Is add them to the house. They already are familiar with the equipment. They can help take care of him too. You know, you have to work. Again, we have to afford all of these things. I don't know anyone who's like won the lottery and sitting on millions as they take care of their kid. If you have a spouse or a partner, you have to give energy to them. And then it's like at the end of the day, like with 0.2% left, it's like, oh yeah, you have to take care of yourself too. Or you even forget that. Some signs of burnout are that feeling tired, not like this normal, like tired, okay, I'm gonna drink coffee and be okay because I got 6 hours sleep, but just you're drained. Like you can't even think anymore. You're just emotionally depleted. Like you couldn't cry even if you wanted to. You know, you're either sleeping all the time or you're not sleeping at all. You know, you might have weight gain from, you know, that's unexpected. You haven't changed your eating and you're gaining weight, or you don't have an appetite and you're losing weight, or even though you're eating, you're still losing weight. You know, irritability and anger towards others. A lot of times this one kind of sneaks up on us and we're biting heads off and we don't really realize it. And then everybody's like, oh, you're being really touchy. And then we get mad because then they told us we're getting mad. And then we bite your head off. You know, being really withdrawn from friends and family. And that's, the isolation piece is huge. But then when we're feeling really burned out, we don't have energy for anything. We don't want to be around others, which then makes it worse because we're isolating anymore. You know, your lack of interest in activities, and just, you can't concentrate. You don't remember the last time, like, did you give that med? Did you not? You know, have we eaten lunch? Have we not? Like, you really have struggles with that. So one of my best examples of this is I had this family that I worked with a couple, probably 7 years ago now. And it was the mom of this kid who had been in the hospital. He was in the ICU for weeks. He had a really serious, he was just really, really sick. And it was touch and go for a while. And mom was like so organized and had her notebook, took notes, like doctors were just, everybody was impressed at how well she was handling all of it. And she just seemed on top of it. And I would go in and check into it. We would go sit and we would talk about everything. And she would talk about how she was stressed, but she was doing okay. And she was making time to do all of these things. And then one day I go see her and she goes, Dr. Wallace, I need to tell you about cookies. And I was like, okay, cool. Tell me about them. And she goes, well, I went to my car to take a break last night. And I was looking at the insurance paperwork and just going through things to keep it straight. And my friend had sent me a basket of cookies for us to eat while we were at the hospital. And so I was like, you know what? I haven't let myself have a cookie yet. I'm going to grab a cookie. And she reached back in her back seat, got a cookie, and bit into it. And she was expecting a chocolate chip cookie. That's her favorite cookie. She really wanted a chocolate chip cookie. When she bit in the cookie, it was an oatmeal raisin. And she lost it. She was like, I was throwing, I was screaming, I am shocked security did not come to my car. And she was like, how effing dare that cookie be oatmeal raisin? Who sends an oatmeal raisin cookie? That is the worst cookie ever. Why did I get to go oatmeal raisin? And just like went off because this cookie was not chocolate chip. And she goes, you know, after I calmed down and like went off for 30 minutes, I sat there and realized it wasn't about the cookie. The cookie was just the last straw. And that was my signal that I'm not doing as well as I thought. And, you know, I really, you know, have to sit there and look and realize this isn't easy and this is really hard, and we talked about it. And so from then on, she kind of has like this whole thing that she does with her is she would talk about cookies, and she'd be like, you know what, it was an oatmeal raisin moment, or it was a chocolate chip moment. And I thought it was such a beautiful example of like, it's never the big thing that we melt down about. It is literally the smallest, dumbest thing that like shouldn't make us melt down that we're gonna melt down about. It's not finding, you know, a shirt. It's not a cookie being what you want. But those are kind of the signals that we need to use to say like, okay, I need to pause and look back. So the other really hard thing to talk about is siblings, is, you know, with kids with any medical condition, but especially kind of the more serious ones like Duchenne's, is siblings kind of become the forgotten voices. It's not intentional. It's not that you love those kids any less. It's just they squeak less. They're kind of being typical. They're doing what's right. And when we look at how much energy that might go into one, the other ones kind of fall in the background. And it's not always the case. Some families have figured out how to balance it well, but sometimes it even kind of gives and takes depending on what's going on. And typically siblings fall into one of two camps. Sometimes it's a combination of both, sometimes it's neither, but siblings tend to either be really independent and kind of raise themselves and be really resilient, and people are like, oh, well, there's Sally, she's just like a little young adult, like she's able to do all these things independently, which is kind of nice because she can, you know, when she turns 16, she will definitely be the errand girl, and you know you can trust her with car keys, and, you know, they can do stuff. Or they also sometimes become caregivers, and this is true especially when we have, you know, single parent household, or when care is a lot, is they become the one to help with care. They learn to care. And typically siblings happily sign up for this. But they also, when they enter in that caregiving role, they also become another parent to their sibling with Duchenne's. And they, you know, it changes that relationship because they're the ones like checking on them, making sure their needs are met. They're doing like intimate care that might not necessarily be done. You know, sometimes siblings worry about going on sleepovers or going to sports camps or stuff because who's going to take care of, you know, your child with Duchenne's? And as parents, sometimes we have to check and be like, no, you get to be a kid. You still want to do this. And a lot of times, like, I think they also feel forgotten because it's like they might be like theater or basketball and stuff, and you might have every intention to go to their sport, and then your other kid gets sick, or we don't have ability to get, you know, your other child in there. And so it just makes it like really hard for siblings. And oftentimes siblings either kind of perceive that their health isn't taken as serious. They might not even bring it to you as a parent because, you know, well, I'm not sick as Johnny. Why does mom care? Like, I'll be fine. Or sometimes that's their reality, unfortunately, is you're so sick of going to the doctor for, you know, your child that has Duchenne's that it's like, well, it's just headaches, you're fine. Or, you know, speaking of like the female carriers is, well, you know, you just need more water. Like, it's okay. And we don't necessarily take their health as serious. Again, it's not intentional. It's just kind of a side effect. We don't take our own health as serious, as we feel like, yeah, I've been run down and not sleeping well, you know, I'm probably just tired, rather than like maybe you do have, you know, a heart condition, or maybe you develop diabetes because, you know, we're not checking on it. It also creates differences in the parent-child, like in parents' relationships with children that are not affected is it's different because, again, you might not necessarily be like as involved in their school or as involved in their life, and they might have to, like, they either perceive or in reality have to figure out stuff on their own. And it changes sibling relationships. Sometimes it brings them really close. Sometimes there's underlying rivalry, or there's like a lot of resentment, and sometimes it's the child with DMD that kind of resents the other siblings, is, why do I have to go through this but you're healthy? Like, why did I get the bad genes? Again, just give me a new pair of blue jeans. I don't need these jeans. And, you know, the siblings, it's just a weird dynamic. And, you know, oftentimes with siblings, we either overload and overshare the information because we want to be honest with them and let them know. But when we overshare, we put kids in that adult parentified caregiving role. And it might not be stuff that's like they're developmentally able to manage. And a lot of times, some of these kids that seem to grow up fast, they seem to understand things way more than they actually do, but we perceive them to. Sometimes they do understand things a lot more, but it kind of also takes away from their childhood. Or as parents, we do this too. We try and protect them, and we don't share what's going on, and we try and downplay the seriousness of it. But I will say kids are really smart, and kids know way more than we tell them. And even when we try and protect them, kids already know. And siblings already know, and they're always like, yeah, well, mom and dad aren't telling me this, but I've overheard X, Y, Z, or I've seen it happen. And so it creates trust issues. And again, they're at their own increase of, you know, the anxiety, the depression, all of this. So a lot of times we don't hear anything or give them attention until, you know, their health is at risk, or they have more issues, or they're having issues in class. And then again, we're stressed out parents. How are we also going to balance this child's school when they're acting out in school and everybody's calling them a bad kid and teachers are trying to kick them out or put them on behavior plans? And really, it's just that kid is telling us he needs or she needs something that we're not able to give them yet. So, not to be all negative, there's a lot of protective factors that keep these things from happening, and one is knowledge. You know, Dr. Bradford did a great job of saying this, but like DMD families, y'all are knowledgeable. You don't just like listen to us, you do your own research. You talk to other parents, you look through foundations, you know about the case, you know about the medicines, you wanna learn it. You're like, all right, if I'm gonna get this degree, I want all the information that I can get to go with it. Having a strong connection to your medical team, you know, feeling part of the medical team and not a them versus me situation. You know, feeling like it's almost like we're all supporting the same cause, and having that connection, being able to send them a message or chat and be like, hey, this little thing is off. Feeling like that you're heard from the team is huge. Having community support, such as Jett Foundation, such as MDA, you know, being able to talk to other families going through it, because like I said, I don't know what your day-to-day looks like. I can't even imagine going through it. I know what I've seen and I know what I have like walked alongside, but I'm not in it. And so another family, another provider who might be in it, you know, having that social support, even outside that, having the family that asks to help, you know, having the community that wants to help and sees you as equals. Having, this one's fun, and a lot of my families do great at this, having family interest and connection outside of DMD. Like, I have families that love baseball, and so the whole family goes to different baseball games, and they make that a priority, or they watch it at home. Or having, you know, different hunting sports. Like, the thing I love about South Louisiana is, like, I've seen some epic wheelchairs and, like, epic setups to get these guys out hunting, and I love it. Like, being able to see them as more than their condition. Having kind of a neutral outlook and perspective, you know, balancing the hard days with the good days, being able to recognize the strengths, being able to recognize the strengths of yourself and the family and the team, and not hear like everything bad from the medical team. Something I really try and get my medical providers to do is anytime you give news to any family, no matter how terrible it is, find 3 things that are okay. Find 3 things that you can give them that can say, you know what? Yes, all this bad is happening, and this also happened. Because if we do that, we help everybody have a neutral perspective. It helps us stay balanced and see that, you know, even with bad, there is good. So I also like to talk the mental health benefits of having a child with Duchenne. I will say, my families, there's a greater appreciation for the small things. When you do find that vacation spot that you enjoy it to the fullest. You know this is a place we're gonna come year after year. This family vacation meant that much more because you know not to take it for granted. You know, you realize how precious life is. You realize how important the little things, such as walking down the hallway, are. You realize how the hugs and the meal enjoyment, you get it. You also have a living superhero in your midst. Like, your children are amazing. They, you know, when you look at them and they keep going every day and they transition to the wheelchair when it comes, and they keep, I mean, I love the show Lego Masters. I would love to do a Duchenne Lego Master like show, because these kids build the craziest things with Legos, and I commend them because like I can't even build like a 3-year-old Lego set, but like they're in here building like Hogwarts and all these things, and I think that is so cool because they can accomplish more than what we give them credit for. I am sure there are times you've had doctors tell you like, oh, well, you know, he has cardiac failure, or like we're in the wheelchair now, and speak it as negative, and then your kid is like, hey, watch me do this, and then proves them all wrong. And I always tell parents, like, doctors love it when kids can prove us wrong. Like, it is the best when we say, hey, we don't know if so-and-so can do this anymore, and then they do it like for 3 more years, and they do it like even better than we ever thought. Like, that's the biggest compliment. Like, prove us wrong. Any doctor that doesn't like it, send them to me and I'll talk to them. But we love to be proven wrong. And you as a person can accomplish more than you ever thought. Like, you might be a parent who hated needles, hated blood, avoided hospitals at all costs, and now you're here, you know, changing, you know, maybe a diaper and setting up a G-tube, and, you know, blood, you're like, all right, whatever, let's deal with it. And, you know, figuring out a wheelchair and taking your kid and seeing all these tests and learning what an echo looks like. And you might even push yourself to like have a greater purpose, that you thought this situation would send your depression spiraling, and you're not depressed right now. You keep going and you find purpose, and you can do way more than you're capable of. And I think that's beautiful. And like I said, it also strengthens a lot of families, is you know what true love and commitment are. And your family comes together, and your siblings know that, you know, that bickering over whose Lego set it is isn't important, because actually being together is important. And so I think that's really beautiful. So for the longest time, everybody always talks about in an airplane, you have to put your mask on first. And even like this always came up in grad school, and I was like, okay, I get it, but no, like if you're on a plane, you're of course gonna put like your kid or whoever's hurt on first. And then finally it kind of clicked for me, and it might be because I'm blonde and maybe a little slow, I don't know. But it finally clicked when someone explained, if you don't put your mask on first, you're gonna be passed out, and so is all the kids, so nobody's gonna be saved. And it kind of being explained that way was, oh, that's why we have to take care of ourselves first. If we think of a firefighter, you know, if an elementary school's on fire and all these kids are hanging out the window, the firefighter doesn't jump out of the truck and run in. He takes, you know, however many seconds it takes to put on his equipment first. Because if he ran in without equipment, he would be taken out in the hallway and no kid would get saved. But if he takes a few minutes to put on his equipment first, he can then go save all the kids. And that's true with the air mask in the plane. And that's true in life. We have to take time to take care of ourselves, to eat, to sleep, to do the things that help us feel like us, so that we then can keep taking care. Because any of you in this room who are a caregiver, if you don't take care of yourself and end up in the hospital with, say, you know, a condition that you didn't know you had because you never listened to your body, who's taking care of your kid? Who's there to know all the doctor visit information? Who's there to do the feeding tube and stuff? And who's there to tell your other kids they don't have to be the caregiver? So that's why we gotta take care of ourselves. So what do we do about all this? Like, I'm doom and gloom and throwing all this at you. What do we do? So this is my favorite example with kids, is I say when we have a medical condition or situation, we can be a plain cheese pizza, where that's the only thing about us. You're just a family with a kid with Duchenne. Your child with Duchenne's Duchenne Johnny. That's the only thing. Only thing we ask about is we only ask about their condition. We only ask about their health. If he's only a cheese pizza. If I take any of these pieces out of this cheese pizza, all I'm getting is cheese pizza. Every single piece looks the same. That sounds really boring, and that sounds like not like a very fun life. So I encourage kids and families to be a supreme pizza, where a supreme pizza can have anywhere from 5 to 10 to 20 toppings. Anything can be put on a pizza. And if I cut a piece out, no two pieces are the same. And so there might be days where that cheese is still there, the medical condition's still there, and it might be more prominent. And it might be like, okay, we need to focus on this. But there might be another day I take out a piece where like there's only a little cheese, and you know, we're focused on baseball, and we're focused on joking around and being a family and traveling. And they're really funny, you know, the joke teller of the family. And you know, their siblings teasing them about their hair, or they're chasing them down the hall. And it's kind of like for that moment, we almost forget that Duchenne's even exists. Like, we see past it. And so I encourage families to have more supreme pizza moments where we're focused that, yes, it's there, but that doesn't define us, that we are defined by everything else. So I alluded to it earlier, but all of our brains need these 4 things to function. And to get a little scientific, our brain works from the back to the front. The back of our brain is what keeps us alive. It is what forms first when we're in utero. It's what our heart rate, our respiration rate, our signals to our heart, all of that is in the back of our brain. And it's really selfish. And the front of our brain is where our mood management, executive functioning, decision-making, anxiety management, pain management, impulse control, patience, all of that hangs out right here in the front of our brain. It's the last to develop. Some people, we're still waiting for it to develop in their 30s, 40s, 50s, and all that. But our brain needs these 4 key sources of energy. It needs to move every day in some way. I'm not saying like CrossFit, like intense exercise, but getting out of bed, moving. We need nutrition. We need constant nutrition throughout the day, not just one and done, like, hey, I ate dinner, or, you know, I ate just breakfast that day. But, you know, that continual, like, sugar and glucose and nutrition going in about every 3 to 5 times throughout the day. It needs hydration. It needs water. Like, our body is mainly made of water. And it needs sleep. It needs time to shut down and just kind of not focus on anything, but like restore and the basics. And anytime our brain in our body is low on one of these areas, it really struggles. And if the back of our brain is really selfish, that leaves no energy for the front. And so it's going to become dysregulated. I always say, we're going to turn into hangry, tired toddlers. Anyone who has a 2-year-old knows that a hangry and tired toddler is like a little like gremlin running around. You can't reason with them. They're going to get upset about everything, and we all have that inside of us. And so the other thing is, like, say we're really sleep deprived. What do we usually do? We eat. And it's because our brain is saying, we're missing energy, we need something, and it's not thinking straight. So it's like, well, maybe we need more nutrition. Well, then we're eating all this time, and then we're weight gaining, and then we're still not sleeping. So our brain lets us know that it needs something. And these key things, if we can do these, or at least 3 of the 4 of these as much as possible, it sets us up for success. Like, most of the time when I work with especially teens and they're telling me like they're having a lot of anxiety, I'm like, how are you sleeping? Well, I stay on my phone all night, I don't sleep. And I was like, well, okay, let's put your sleep under control. And it's amazing how that cures it. And or it makes it better. It might not cure it, but like, we need these things for our brain to function. It's not just people harping on it. So this is a huge way to improve. With siblings, it's really important to kind of carve out that individual time with each sibling regularly. It can literally be a 10-minute check-in, and it's kind of like having a routine about it. How do we, like, what do you enjoy doing together? Maybe you and, you know, Sally really like to cook dinner together, and you don't have to talk during that, but you're not going to talk about anything negative. You're not going to talk about sibling. There's no feedback like, well, why didn't you do your homework? Why didn't you do this? Or them saying, Mom, you're just not fair. You always let him get away with it. And you just even sit there in silence and do it. I have some kids that, like, when they're teenage daughters, they have daddy-daughter donut date, because when they're cute 4-year-olds, daddy every Saturday morning takes them to the donut shop. But that kind of goes away when they're preteens and nightmare, and so then dads and daughters don't relate anymore. And so something we bring back is, hey, Saturday morning, get up and go to the donut shop, because it reminds you of something you did when they were little, and it ends up being a connection. And so reestablishing that connection, and it doesn't have to be every day, but just a couple of times a week, having that one-on-one time to just check in or do something besides that. And try and prioritize them. You know, if they have a sport or an interest, make time for that. Try and have someone else, you know, pick up the pieces and really, really try to not like back out because of something that happened. You know, really honor that commitment at least, you know, a couple times a year to show them that they are as important. Check in with them. Ask them, how do you want to be involved? Hey, you're 13 now. What do you want to do? Do you want to help with care? What do you want to do? But I want to make sure that you don't feel pressured to do it. How can we work together with this? And how informed do they feel? Do they think they know all information? Do they have questions? Do they want to know more? Do they want to know less? And kind of letting them know it's okay. But the other thing is also allow normal sibling bickering. Like, it is totally, it's annoying, but it's okay if they want to tease their brother. I always say we don't tease about our medical condition. We don't tease about our limitations, because we should never do that to anyone. So like, if Johnny has Duchenne's and Sally has headaches, Johnny can't tease Sally about the headaches, and Sally can't tease Johnny about Duchenne's. But they can be like, oh, you like Pokemon so last year. Like, let them bicker about normal stuff. and kind of have that family connection beyond the health. Like if you always want to sit together and watch, Lego Masters, or you really love football, really honor that family connection that everybody is a part of as much as possible. This is a huge question. Like I said, I tell all my doctors to give 3 things that went okay, but to ask yourself, and a powerful exercise, I actually did this to myself, this was my Lenten thing a couple years ago, is I kept a journal of writing down 3 things that went okay every day. And it's really powerful, and it's crazy how when you start to do this, at first you might search for it on hard days, and it can literally be, you know what, it's Friday, and I'm happy it's Friday, or it's sunny outside, or I ate, chicken strips tonight, and I love chicken strips, or, nothing went wrong today. Like, it doesn't have to be, like, it's not toxic positivity. It's not like, yes, we're so happy I get to, be in the hospital. No, it's really simple things is, you know what, we have one more day together. Something so basic is focusing on what goes okay. It helps our brain start to notice that even with the bad, there is the good. So this is a really cool tool that you can do, and it is really cool how it works. Another thing is having outlets. So I'm a big supporter of having things that help you feel like you. What did you like to do before you were a parent? What do you like to do that's fun and distracting? Do you like to do puzzles? Do you like to go shopping? Do you like to go for walks or play board games or play video games? What are those things? What do you do that's calming and relaxing? What helps you relax? What uses a lot of energy? If you were an athlete all throughout high school and all throughout your early life and you don't do it anymore, you are missing out on a huge outlet for yourself because your body is used to moving, and runners gotta run. That is how they have the outlet. Having people you can talk to about the problem, and then sometimes talk to about distracting. I always tell my teenage boys my favorite is to talk to them about this because I'm like, all right, who is that goofy kid that you hang out with that your parents are like, why do we let this kid come into our house? That always has the dumbest things, that has the best stories. He's the one you need to talk to when you're really bothered, but you don't want to talk about it. He's going to get your mind off of it. So I think doing at least one thing every other day, if you can do it every day, but every other day that helps you feel like you, that is a great way to keep yourself going and remind yourself. So that might be something about talking to your partner about hey, I really want to go for walks. Okay, how can I prioritize things to let you go for a walk? And if you can't go for a walk outside, how can I let you go for a walk in Walmart or, wherever? And really recognizing that taking that time for yourself isn't selfish, but it's actually giving because you're replenishing yourself to help other people. Talking about Jett Foundation, they have family workshops today, that support is huge. Doing the porch nights, the monthly carrier conversations. I really am encouraging a lot of my patients to get back to going to camp, having that connection. I know there's a lot of anxiety with a lot of my kids to go, but having that connection, separation from parents a little bit, that is great, and those are definitely ways to kind of help everybody cope. Any questions? Comments? Yes? Thank you. Thank you for listening to my rambling. Any other questions? Comments? All right. Well, thank you all for letting me be part of your journey and present. If you do have questions, email me, let me know. I'll happily touch base and answer anything. But thank you for letting me be here today.
Awesome. So I'm going to poll the room. 5-minute break or keep going? How are we doing? He's like, I need a break. How are we doing? 5-minute break? All right, let's do it. We'll just come back at 1:20. Okay.
Show you this.
Sure.
I didn't think about this. She was mentioning wheelchairs and then families
Yeah.
trying to do things and everything. My husband's director of Louisiana State Parks. They just put in all these all-terrain chairs.
Like that you can rent?
Yes.
Nice.
So you rent them, and then you're able to get, if you're in a wheelchair or whatever, you have to have someone 18, of course, to accompany you, but you're able to get out and about in the state parks with these chairs.
Email that to me. That'd be great, because I'll send it, actually, we like do follow-up, and I can send that as a follow-up. Because I think it's really,
I mean, and the lieutenant governor has been big on this. So he's also doing all-inclusive playgrounds as well. He's putting one in. They're putting one in Fountain Blue State Park.
Okay.
And then they're going to be doing the first ones, but they're going to be doing other ones. And then there's 11 of these out and about now, at least one in each park.
So
and you just get online and you reserve it, and you can afford it.
So at least you know it's there when you get there, rather than like going and it not being available. I love that. Thank you. Yeah, please email me that.
What's your email?
Alexa. No, just Alexa. Yep, at jettfoundation.org. Thank you very much. Thank you. All right, everybody, we will go ahead and get started. I'm going to bring up Trina Stelly. She is one of our resource specialists, as you all have learned, and she is also a mom to Austin and Aubrey, who are affected by Duchenne, and she herself is affected by Duchenne.
Hi, everyone. As Alexa said, my name is Trina Stelly. I am local to Louisiana, just in case you didn't know by my accent. I live around the Lafayette area in a small town known as Orneville. We actually have 3 children. My oldest son, Ethan, I don't want to say he's not affected by Duchenne. He doesn't physically have Duchenne, but as you've heard some presentations from Dr. Wallace, the siblings are very much affected. And then my middle son, Austin, was diagnosed with Duchenne when he was 5 years old. And then my daughter, Aubrey, was also diagnosed when she was 5 years old. And I found out I was a carrier after Austin's diagnosis. Back then they said, don't worry about it. Most females don't have any symptoms. You're probably not a carrier, because I'm going to back up a little bit. I am the only female in my family. I only have male siblings. We had never heard the word Duchenne before. We have no family history. So Austin's diagnosis was quite a surprise. And at first I'm like, okay, I wasn't too worried about it, but they did have me get tested, and I found out I was a carrier. And I don't want to say I didn't have symptoms. I didn't know I was having symptoms, because I was under the impression that girls could not be symptomatic, so whatever I was feeling was not because of my carrier status. And over the years, I found out I was very much symptomatic, and my daughter as well. And so I dislike the term carriers. I prefer the term female with dystrophinopathy, or a symptomatic person affected by Duchenne, because I feel if you tell someone that you're a carrier, then they kind of brush it off. Well, you can't have these symptoms because it's an X-linked disorder and girls don't have symptoms. Whereas if you tell someone you're a female with dystrophinopathy and you're somewhere on the spectrum, they kind of pay a little bit more attention to you. If you get diagnosed with heart failure or the arrhythmias or even the physical symptoms, I was fortunate to participate in a study, the University of Florida in Gainesville, where they did MRIs. And through that MRI, I found out that every single muscle I have is affected. Some of them are more affected than others, and I've kind of adapted my physical abilities over the years. And I will say, and I kind of talked to Alexa about that I was glad my son was diagnosed when he was. That may not make much sense, because I really wish he wouldn't have been diagnosed at all. But where I'm at currently with being a symptomatic female with Duchenne and where he was would not have worked out. So I was lucky that I was able to be in physical condition that he needed me to be in for me to take care of him and give him the best life possible. Unfortunately, Austin passed away in 2021 when he was 17. Sorry, we're getting closer to that 3-year mark. But like Dr. Wallace said, he was a supreme pizza. He wasn't a cheese pizza. We did everything we possibly could for him to have the best life. And he loved to hunt, he loved to fish, he loved going to the national parks, he loved driving us bananas. And we currently own a zoo, basically, because Austin loved the zoo, and he got to the point where he couldn't go to the zoo. So we bought a zoo, and we brought it home to him. And now I get to take care of the zoo on a daily basis. So that's been really fun. And my daughter is currently 16. Dr. Bradford couldn't share that she was her doctor, but she is, and we're very fortunate to have her, and she is one of her extremely symptomatic patients. And she, physically, she can do okay. She does get really, really tired, but her heart has given her a lot of problems. And we found out when she was only 13 that she already had cardiac fibrosis. And at her next MRI, her fibrosis had increased, and her ejection fraction is also dropping. So I just want people to be aware that this is a real thing, and females can and are symptomatic, and it's happening on a more frequent basis than anyone originally believed. The numbers aren't out there because there's just not enough data to support that. I'm hoping to help with that, and I don't mind being the data. But I just want you to know that, you know, this is real, and like, it's really great that we have these new therapies on the horizon, but I don't think females should be excluded. I understand that there's no trials allowing us to try this medication to see how it would affect us, but we need access to these medications as well because we are symptomatic. And yeah, that's just what I want to say. I'd appreciate that. And if you have any other questions or you need data, or I can connect you with other families, because me being one person standing up here and saying, hey, girls are affected, I can put you in touch with other families. Like, there really are a lot out there, and a lot of them are suffering in silence because they're being told that this is not a real thing, or they may be suffering from caregiver burnout. And that may very well be the case, but if they have physical symptoms that are wearing them out, and they're seeing about themselves last, like they're trying to pour from an empty cup. Their body is physically fighting them, and they need to be in the best physical condition to be able to take care of their children. So this is very important, and I'm glad the conversation is out there, and the pharmaceutical companies are understanding this, and that there are doctors out here that are specializing in treating us. The Carrier Clinic at the University of Pennsylvania, they're one of the only clinics in the country to treat adult females, and I'm fortunate to be part of that clinic. And a lot of the pediatric clinics, if they see, they're treating the siblings. If there's a female sibling or the mom, they may be able to treat her as well. They're starting to see this happen more frequently as well. I think that's it. It's been a long journey. I think it's been 14 and a half years, and we've seen so many treatment options. And for the new families out here today, just want to say hope is very important. And just because this was our journey doesn't mean it's going to be your journey. And there's so many new treatment options on the horizon, and these boys are truly living, long lives and fulfilling lives. Like, be the supreme pizza. Let them find things that they're interested in and do that. Travel was a big thing for our family. It was very difficult, but it was something that our son enjoyed and the rest of our kids enjoyed, and we just made that happen. And I'm sorry I don't have a presentation. I was told to just come up here and maybe just wing it, so that's what I did. I think that's it. Does anyone have any questions about being a symptomatic female? Okay, Alexa? Okay, that's a very good point. So when I was told I was a carrier, they didn't suggest that we have our daughter tested, because I already had all 3 of my children before my son was diagnosed. But as she got older, we started noticing some symptoms, and I'm like, there's no way. Like, she was having trouble climbing up and down the steps. She was just tired all the time, and it just felt like deja vu. And I'm like, they told me this was not possible. She could not be symptomatic. So I brought it up to her pediatrician, and she didn't want to do the genetic testing right away. She wanted to check her CK levels, and her CK levels came back elevated. So then we did the genetic testing, and we found out she was a carrier. And for us, finding out at an early age was important, because had we waited, she's having severe cardiac issues. Had we waited until she was over the age of 18 to be able to consent for these tests, her heart may be, it may be at the point where it would have been damaged beyond repair. So because we found out early and we had her first cardiac MRI early, she was able to start these treatment options. And she's currently on 4 different heart medications, and we're trying to get her stable. And with me, my cardiac issues didn't hit until I was in my mid-30s. And December, I kind of had a scare, and they told me I was going to need a defibrillator. I didn't need the defibrillator just yet, and both of us have internal loop recorders. So it's like a Holter monitor, but we're constantly being monitored. So when our heart does go into the abnormal rhythms because of the fibrosis we have, it has impacted the electrical system of the heart. So our heart goes into these abnormal, dangerous rhythms. And so we're constantly being monitored. And if it becomes the sustained ventricular tachycardia, then we both get the defibrillators. So I'm glad that we know about it. We know what we're up against. We're taking these medications to prevent it. But had we waited until she was older, it may be an entirely different situation. Jess? So it depends on the center. So some of the big centers like Cincinnati or Nationwide, they are recommending the moms get tested. Some of the smaller, centers, they may not be aware of how many females can actually be affected, so they're not recommending it. But like organizations like PPMD, they do the Decode Duchenne. So if there's an affected male relative, they are doing the free genetic testing for any female relatives. And it's not just the siblings, it's the moms, I want to say it's the grandparents, and maybe like aunts. Yeah, some of the insurance is still, they want them to be over the age of 18 because of reproductive issues. And like I'm trying to explain to them, it's not just reproductive issues. And if we have to choose, their lives over reproductive issues, then we have to know about their, their heart health and their muscle health. So I've been sharing this with everybody and anybody who will listen because it's so important. And I mean, I'm older. I like to say I'm not old, but I am old, unfortunately. So these treatment options on the horizon may not help me, but I'm not doing this for myself. I want it for my daughter's generation, or, by the time she has kids. I just want them to be here for a really long time. And if I can do my part to educate people and, try to get females treated, then they can be here for a long time. So it's not about me, it's about the next generation. So, thank you.
And I think, to her point too, and kind of like what, Jessica was saying is, I think more and more people are realizing that even with reproductive issues in mind, having the knowledge to be able to make those decisions is important. I know that, it's becoming bigger with PPMD, Cure Duchenne, us, like the more knowledge, the better, so. And with that, I am gonna go ahead and bring up Jessica Round to share her experience as well. And you can either click or click.
It's easy, thank you. Okay. So I'm Jessica Round. My son has Duchenne. So many of you families know me already, but my husband and I have been married for 20 years. I have two sons, Wyatt's 17 with Duchenne, and Winston, like Trina said, he is affected, but maybe not with the diagnosis. He's 14, and we also have a service dog, Wrigley. Let's see, that's not it. Let's see, come on. Did I hit the wrong button? Let's see. Oh, there we go. Okay, so that's my crew right there. So I usually get up and speak about behavior issues in Duchenne, why it's severely affected with all of that, and but today I decided to talk about something a little different. But if you have questions about behaviors and your child's a jerk, talk to me, because we deal with that a lot. Wait, I messed up. Let's see. So my story in a nutshell, Wyatt was diagnosed in 2007 at 15 months old. I was working in the pediatric ICU as a nurse. And at Wyatt's one-year checkup, I was raising some concerns about his poop, which led to many, many tests and lots of roads that led to nowhere. And he was finally diagnosed. We couldn't believe it. Even as a nurse, I had no idea what they were talking about. We have no history of Duchenne in our family, and unlike Trina, I'm not a carrier. So he didn't have any symptoms. He pretty much just had the football calves, we called them. Like, we just thought we were gonna watch him as a little football player for LSU, but not so much. Obviously, it's a telltale sign of Duchenne, and we were given the diagnosis on Halloween 2007. So that's them. Wyatt never dressed up. That's all the behavior stuff. He kind of just shuts that all down. So we were told to go to Texas Children's, and the doctor there told us there's nothing you can do right now. Go home and love him. I mean, seriously, how was I supposed to take that? Totally broken. So I had nothing but go home and love him, but I was ready to fight, and my husband was ready to fight. We wanted to find a cure, we wanted to raise money, we wanted to run marathons, we were gonna start a nonprofit, we were gonna advocate for families, but reality, there was no way you could do all of it. It's exhausting. And really, I just wanted to curl up in a ball and cry. So I tried to do some of those things, and as I look back on it, it was just a way to distract myself from focusing on what the future holds and what I thought life should be like. I was grieving. Nobody told you were gonna grieve at diagnosis. So now, when I hear of someone's son or daughter getting diagnosed, I try to think of what I would have wanted to know. And some things some of the physicians told me when I went back to work has always been in my heart. He asked how I was doing. I told him my worries of the future and explained how Wyatt's behaviors had been so extremely hard to deal with. I was tired of thinking of what our life was supposed to be like, and tired of being judged, and tired of feeling that people were always looking at us when Wyatt was having his meltdowns. Dr. Finger looked at me and said, "Jessica, think of it like this. For 9 months while you were pregnant and for the past year, you thought you had an apple, but you really had an orange." And I thought the psychologist was gonna really steal my, my thing, but she didn't. So he said, you still have your sweet son, and he's not exactly the same, but just like there are differences between an apple and an orange, there are so many things that are the same. Stop looking at his differences, because that's not all Wyatt is. He's not Duchenne, he's your little boy. So I tell you that story because lately I've been thinking about the differences in my life has turned out compared to our friends, our neighbors, and even just acquaintances on the street. There are many times of jealousy, of course, but when I look at all the things that have happened because he was diagnosed with Duchenne, my heart is truly full. We have met so many people who want to make sure we make the best of every moment. Wyatt has made friends that include him, and when he can't do things like them, they have figured out a way to keep him involved. For homecoming this year, he took pictures with his brother and his neighborhood friends, and then had a small gathering with some other friends at our house. Nope, didn't get the formal pictures, but I got a lot happier Wyatt. Sorry, excuse me. I learned over the years that what is expected of our high school years and what is not what's going to happen with Wyatt's experiences, and that's okay. We have worked extremely hard to make all the high school years and all of his school years the best he could have. We are finally able to get the teachers on board with seeing Wyatt's success is not the same success as everyone else in the class. And it took years, and for me to come to terms with that, with the school expectations, but it finally did. And we got he will graduate in class of 2025, and he's getting his senior ring next month, and in the inside he put, "I survived." So as I look back on the past 16 years, I wish someone would have told me that this is a marathon and that not everything needs to be done now. Marathons are exhausting. At diagnosis, I wish the doctors would have given me a handout that I could have read when I felt ready to acknowledge the new life-changing diagnosis. I wish I would have had a list of groups that were out there. There definitely weren't so many 16 years ago. And I wish I could have had a mentor to help guide me through clinical trials, best clinics of care, advocacy groups that help with raising awareness, and the ones that can help with financial issues. I needed a friend because this diagnosis is lonely. Many of you have had the same experience of losing friends that you thought would be there for the long haul. I'm here to tell you that if they left, they probably were not the people to be on your journey. So that's my friend Lindsay, and she's in our neighborhood, and then Michelle, who's not here, who we've joined together and supported each other. I do want to say, especially since we have all the pharma people here who put their hearts and time into finding a treatment for our boys, that over the years we have chosen to get wide into multiple trials, 4 medical trials and 2 research studies. Not all were great experiences, but I believe we were put in those trials for a reason, and we learned so much for them. He has gotten, as he's gotten older, he kind of makes the decision on if he wants to join it or if he wants to get out. He got out of one last year and then joined into another one. I'm just here for the ride and the heavy lifting, because that's really what I do. Because if you know, travel is not easy, and there's not really accessible vans for you to just rent while you're there. I let him make his own informed decisions, and months later, we discussed consequences, and he was able to make an informed choice to stop one of the medications. I'll talk to you about that later and tell Pharmaco. And so we had to travel, but if he was on board, we got up and did it. Participating in the clinical trial is not for the weak. It's hard on everyone in the family, and with time away from school and work and other family members, it's not easy for everyone to be in a trial. It is rewarding knowing that we're able to move science forward and hopefully to get some of those meds available to our boys and girls. So I want to leave you with this. I've been a mentor to new diagnosed families in our community. I have actually created a packet with information that I mentioned earlier. If you would like a copy, give me your email address. It's got letters for your schools and letters for doctors and just helpful tips. I started a blog, and that's more helpful to me possibly than other people reading it, but it's a way for me to process my emotions and go through my head constantly. It's easy for us as parents to get lost in the everyday of living with Duchenne, but finding a purpose beyond that is important too, and will help you be a better caregiver to your son or daughter. So like we said, the hunting and shooting guns and riding in 4x4s, this was over Christmas. So get out there, stop, it's hard to do, it's hard diagnosis, but reach out. We're all around here to help. And that's it. Any questions? Yep. That's okay. Mm-hmm. So, Jett Foundation has obviously these things, and PPMD does have a conference. Jett goes to that too. It's every year. This year it's in Orlando. It's really getting together with just people who know and understand, and you don't have to give your backstory of how you're feeling to just get that love and support. I mean, I think I have a list, like I said, of all the different groups that are around that definitely help, and y'all are kind of been helping bridge the gap of, there's just so much information out there, it's hard to kind of process all of it and find people, but I'm happy Angela found us. I try to get our group, at least in Louisiana, welcome Mississippi, to come and, we try to do a World Duchenne Awareness Day just so we can have families together that support one another. I think there's probably, 8 to 10 of us that are pretty close knit, or live close to each other. So we try to keep together on Facebook, and, it's... But I don't and help to figure out where to go for care, because I think that's hard down here. I know we talked about it with the Children's Hospital group, but finding a team here at home is important too, because our kids aren't going to get sick on that time we're just up and getting our well check, up in Arkansas or Columbus. So I think finding that team here that knows your child, that can help, get that done while you're home is very, very important. So if you need anybody, if you need to know who my team is, I'll let you know. Yeah. Yeah, because I want to say Trina and I have been knowing each other since diagnosis of both of them, so. Yeah, that's like my favorite things to talk about. Cursing is usually one big one when they're cursing at you. Wyatt is older, but I would say there's some really good resources that I can give you to watch, but I can kind of give it to you in a nutshell. Is the dystrophin in their brain changes their brain and behaviors. So treating them exactly the same as my other child is not, it doesn't matter. I could beat Wyatt and it would, 10 minutes later, he'd be doing the same thing. Totally opposite for my other kid. But their brains just don't work the same. I'd like to say that if you could check the box of autism for a lot of our kids, because there's so many behaviors that look like that, it would get a lot more attention. But I feel like we're getting closer. But they're so rigid thinking, and then when they get overstimulated, it's done. And once you get to that overstimulated, frustrated state, just stop. Because they're not going to come back for a good, sometime when Wyatt was little, like Ethan's age, I mean, it would take almost an hour, sometimes 2 hours before he could settle himself back down. So just frustration, just mad. And so it took us and my husband a long time to figure out, we just need to step back. I say we figured this out, but yesterday he's yelling and I'm yelling at him, and then I just walked out, and 20 minutes later went back and he was crying, and it was like he just finally was able to process it and calm down. And it's just sometimes I like to say, just grabbing the bear and hugging him, because the overstimulation it's just too much. And so, like I said, losing friends, like we stopped kind of going places for a long time because we hadn't figured out how to manage it. So homework's tough. We're barely going to school, but I think it's more of just recognizing if it's too much and if the homework's too much, just tell school we're not doing it. You don't, get through a few problems to make sure they know it, and then that's good. Because sometimes their little brains just can't do it. But I'll give you the resource with Dr. Struba.
And then I also, I lean on them as well to talk about IEPs or 504 plans to make sure that those needs are met and understanding of what that looks like for that child. And that will also help you better process what that looks like to you.
Yeah, definitely. Because schools a lot of times don't understand and just want them, they just see the physical, and sometimes like when he was younger and he could still walk, they didn't even look at the physical, and all they saw was behaviors and just wanted to kick him out. And so I think that was probably a really hard part with that. And so now as we've gone through school, he goes to school 2 days a week for 2 classes. He gets to sleep, and sometimes, and if he's acting like a fool at school, I just pick him up. Luckily, I work from home. So I think it's just getting people to read the signals. And unfortunately, it's just so many different ones. Like his aide would say it was tapping a pencil. And when he started tapping, she's like, I got to get him out. So just different things when they're getting too much.